Thank you for that summary.
Oh, you're welcome. I hope it was accurate. And and Holly asked me about the meeting, so I told her that I also sent you some resumes. Yeah.
Were there people weighing in?
There weren't, actually. The main thing for the discussion was whether it would make sense to contribute some money if Cerner was chosen and not Epic. In general, I think people felt like if it was Epic and not KX, they would still feel like it was dollars well spent, so they would be in favor. Especially since they come with money to be there for the right foundation for that business. I think the concern was that if there are funds like we have the university side of things, like the university and the foundation, that the money might be potentially useful for CSM not funded, and that could actually cause major issues. They're citing some experience on the CSF side of things with implementing the EHR, but I'm able to get into the dynamic, I guess, campus concerns versus independent responsibility. But they didn't go into any detail for like I think sharing logs probably was the most probably the most yeah. But so I think again they felt like they wanted to hold on to it for now with possible distribution later if Cerner was appointed. Yeah. Yeah.
But I can see the need for it.
Yeah, I think they're right. I think Tom was thinking that based on the training, possibly it would be needed, that it might be needed relatively soon. But actually, we're not. Hopefully, we'll get a collection this summer, and then take a while before money is needed. But not exactly sure the timeline.
Thank you.
Oh, yes. And I'm happy at your convenience we can talk more about the level of their issues. You know a lot about them, but the hospital still trying to ramp up its resources.
I don't think
yeah. They eat up. But I think one of the things we probably should just figure out what to do is like, we talk to a lot of people now about what it is. And in general, we but like operationalizing it is actually just like a challenge, like getting permission and getting things set up. And then there's also been this sort of idea that the health department has to request to pay for it. And it's really related to clinical operations. Yeah. Yeah. So I was talking to this morning, I think the timeline of that should be, I mean, obviously, possible, but more than so really, we should have this all in place by now. Yeah. I would be very careful. Are you ready? All right. Hi, everyone, and welcome to Medicine Grand Rounds. We are thrilled that everyone is here today. Okay, we're starting to hear our wonderful speaker, Dr. Leigh Kimberg. So Leigh is a professor of medicine, and she is the director of the Prime U.S. program here at UCSF, the Program in Medical Education for the Urban Underserved for the School of Medicine. So just a few things about Leigh. She did her undergraduate at Penn, getting a degree, I believe, in English literature, followed up with a graduate diploma in literature at Queen Mary College at the University of London, just showing how well-rounded our faculty are. She then went to Harvard Medical School and was a primary care resident here at San Francisco General. She has really dedicated herself to practicing in safety net settings. She was at Maxine Hall in the Western Addition, and now works at the Richard Fine People's Clinic, where she's also volunteered extensively and is the winner of our department's volunteer award. She has worked in violence prevention for 2 decades, and she is the coordinator for the Intimate Partner Violence and Family Violence Prevention program for the San Francisco Department of Public Health. But she is also a researcher and is the PI of the federally funded ARISE program and maintains an IPV prevention website for healthcare providers. I'll give you the website in case you want to go. It's www.leapsf.org. So, Leigh, we're just delighted that you're here today. Thanks so much for coming to talk with us about this.
Thank you. Really excited to be here. I find that even 2 decades later, every single patient I see and every single talk I give, I am learning and developing. And in fact, when I sat down to redo these slides, I thought I should have named this Trauma and Resiliency Informed Care. So I'll just give that caveat. I have nothing to disclose. So today's learning objectives, I'm going to define trauma and resilience, actually. I'm going to review how trauma that's experienced in childhood results in adulthood disease decades later and other poor health outcomes. I'm going to define trauma-informed care as well, which is a work in progress and hasn't been well tested, but I'm going to share some paradigms and ideas about that. And then I'm going to continually throughout this talk emphasize that caring for ourselves while we care for others is absolutely essential to providing trauma-informed care. So we are going to start with a group meditation. I know you're eating, but if you can take just a minute's break and sort of feel your weight sinking into the chair and your feet connecting with the ground and the earth. You can keep your eyes open or close them. So take a deep breath, let it out, and then take a moment of gratitude that we've come together as a community of caregivers dedicated to the healing of the most vulnerable patients. Most of us and our colleagues and our patients have all experienced traumatic events. Allow yourself to envision and embody the healing energy of a tree, which breathes in carbon dioxide or trauma and breathes out life-giving oxygen. When each of us, breath by breath, remains physically and emotionally grounded or rooted, We create a forest amongst us that is peaceful and healing, not only for our patients, but for ourselves as well. So breathe in the healing energy of the earth and breathe out peace. Breathe in the healing energy of the earth and breathe out compassion. I think it's really important that as we embark even on a talk about trauma, that we stay rooted in our body and our breath, so that we can remain hopeful about our ability to heal ourselves and our ability to heal our patients. And so I definitely think that whenever we discuss trauma, we should really try and pay attention to self-care, and I'll remind you throughout this talk. So SAMHSA defines trauma as an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects. But if I could crystallize for you what you should think of and what I think of when I think of trauma, I think that trauma ruptures relationships. So it ruptures relationships with ourself, our relationship with ourself, as well as relationships with others. And SAMHSA focused on trauma as experienced by an individual, but whenever I'm going throughout my day seeing patients and colleagues, I'm thinking of trauma and resilience across the socio-ecological model. So trauma and resilience, or protective factors, there are risk factors and protective factors across every level of the socio-ecological model that make trauma more likely to be experienced by individuals, families, communities, societies. And you can actually think of trauma and adversity as really powerful social determinants of health. And they're actually not equitably distributed, right? So trauma and adversity are experienced in a much greater prevalence by vulnerable communities than by privileged communities. And this is really a result of direct structural societal policies that we've designed, right? So this is not an accident that trauma is distributed inequitably. So how common is trauma? The short answer is that it is much, much more common than people generally realize. So there's a national stressful events study that is done, I think it's done annually, but at any rate, it's a representative sample of 3,000 adults across the country. They do actually have internet access, so may not be fully representative of our patients. But even in this population, 90% of U.S. residents have experienced a very serious DSM-5 category traumatic event. And 53% of those adults say that they have experienced either physical or sexual interpersonal violence over the course of their lifetime. So again, this is something that's hidden and much more common than we generally appreciate. How many people here have heard of the Adverse Childhood Experiences, or ACE study? Okay, we're getting there. It's only 20 years old, and it's probably one of the most important public health studies done, actually. But it looks like about a third to a half of you have heard of it, and I highly encourage you to read more about this study. It's a study that was done at Kaiser San Diego, in which they took about 17,000 of their patients, gave them an exhaustive questionnaire about their health and childhood experiences, and then did comprehensive histories and physicals to determine what their current health risk behaviors and health problems were. And what they found, they were surveying on the adverse childhood experiences for 10 categories of abuse, neglect, and household dysfunction. Things like direct physical or sexual abuse, as well as whether you had a family member or someone in the household with mental illness, substance addiction, or incarceration. And what they found is that ACEs are much more common than anyone realizes, even in this white upper middle class population, and that they're very strong predictors in a dose-response relationship to most of the really important health outcomes and health risk behaviors that we actually address, especially in our safety net setting. So I don't have the clickers for you, but just in your mind, guess for yourself how, again, in this population, which was predominantly white and college-educated, mostly employed population, how many people had physical and sexual abuse as children. If you guessed 3, you're sadly, really, that is the correct number. This is a really busy slide, but I really just want to call attention to how common ACEs, or adverse childhood experiences, are. So if you look at the bottom part of the slide, a full 2/3 of this population had experienced at least one ACE. And then if you look at 4 or more ACEs, 12.5% of people had experienced 4 or more. And again, remember, these are pretty serious adverse childhood experiences, and they also only count, just to make clear about the study, as 1. So if you are physically abused your whole childhood every single day, that still just counts as a 1 for physical abuse. And so what are the health behaviors that have so far been studied that relate to adverse childhood experiences in a dose-response relationship? So we can see that adverse behaviors, many of them are related in a dose-response relationship. Reproductive outcomes, future violence is more common in people who've experienced adversity in childhood. Adverse health outcomes, everything from COPD and ischemic heart disease to suicide attempts, and homelessness as well, which has also been studied prospectively rather than retrospectively and been found to be related to adverse childhood experiences. I want to just highlight that these are pretty powerful risk factors, and they're independent of traditional risk factors that we think of when we think of these diseases. So a person with 6 ACEs actually has double the risk of ischemic heart disease. And I really want to call attention to suicide attempts because the relationship is pretty extraordinary. So adults that have 7 ACEs actually have 30 times the suicide attempt risk, and adolescents who have 7 ACEs actually have 51 times the suicide risk. So these are really powerful risk factors. So how does this happen? How does adversity that occurs in childhood result in adulthood high-risk behaviors or health outcomes decades later after these experiences occurred? And what we know is that our experiences and our relationships are actually built into our brains and our bodies and our behavior. And that if we are, as children, exposed to constant toxic stress without the buffering of a safe, stable, nurturing caregiver, that affects actually our neurologic development, our neuroendocrine system, so the hypothalamic pituitary adrenal axis. It affects our inflammatory systems, our epigenetic systems, our genetics as well. So even telomere shortening has been studied prospectively in children who experienced 2 or more forms of childhood abuse, had telomere shortening over the course of 5 years. So again, nature and nurture are in a constant interplay, and we're being built by our experiences. But, and of course, what we want to do is prevent adversity in the first place, that is preventable adversity. But just to point out that safe, stable, and nurturing relationships really buffer the effects of toxic stress and take it down to a more tolerable level when you have a really safe, stable, and nurturing and well-attuned caregiver. And so there's new studies looking at adverse childhood experiences and whether someone had a safe, stable, nurturing caregiver as a child, and the effects of those ACEs are markedly diminished by that safe, stable, nurturing caregiver. This is just here to give you a reference for the science of this and to tell you that the Harvard Center on the Developing Child has excellent videos for providers and patients about the science of toxic stress and the biology of it. So to sort of summarize now, what we think is going on is that there are adverse childhood experiences that are leading to actual body and brain changes that result in social, emotional, and cognitive impairments that lead to the adoption of high-risk behaviors, disease, disability, and other social outcomes like homelessness that then lead to early death. And this slide is always really hard for me to show and read because it's really quite extraordinary how in people with adverse childhood experiences of 6 or more, the life expectancy is 20 years less than someone without ACEs. And so again, I'm just going to remind you, because I do this every time, I can feel that my heart is going faster and my jaw is sort of tightening up. My palms are getting sweaty when I read this slide. And so again, when I'm dealing with trauma, whether it's in slides or whether it's talking with a patient or a colleague, or whether it's just hidden and we're not talking about it, but we all know it's there, I'm trying to stay really rooted and grounded and do my deep breathing throughout the day as I'm caring for people. That's just childhood trauma, and this is just to say that adulthood trauma also has biological effects and is related to a whole host of similar poor health outcomes, even if someone has not had childhood adversity. And then the ACE study really just looked at childhood abuse directly within the family and household dysfunction, but did not look at, obviously, a whole host of other traumas that we experience in society. And the more I delve into trauma, the more I realize that almost all trauma, except perhaps like car accidents, are rooted in oppression and discrimination and really abusive power dynamics. So there's a real continuum, as we're seeing played out on our national stage now, right, about interpersonal violence and abusive power dynamics in interpersonal relationships, all the way through structural violence and how those abusive power dynamics are put into place in society. And what we're finding now is that the independent health outcomes of racism, for example, actually are working through similar biological pathways as childhood adversity. So I like to think of trauma as contagious. That helps me remind myself to stay rooted and grounded and be paying attention to how trauma around me is and within me is affecting me. So I like to think about it as passed on through individuals, families, communities, and society, passed on intergenerationally or historically, and as I've said, through abusive power dynamics. But it's also just passed on to us when we hear stories of trauma as well. I don't want to give a sort of negative impression without reminding us that we all survive quite a bit of trauma and are able to learn and grow from it as well, and that resilience mitigates the effects of trauma. Resilience, if trauma ruptures relationships, you can think of resilience as increasing social connectedness and healthy relationships, again, at every level of the socio-ecological model. So what we're trying to do when people have disrupted relationships is help repair relationships and model healthy relationships. So SAMHSA has defined what they think trauma-informed care should be. And again, these are all aspirational models that are currently just starting to be tested. So SAMHSA defines trauma as a strength-based delivery approach, so again, focusing on resilience and assets. It's grounded in an understanding and a responsiveness to trauma, and that it would emphasize physical, psychological, and emotional safety for all of us in the system, right? It's hard for any one of us to feel as safe or secure, grounded, if multiple people in the environment are disrupted. And it creates an opportunity for us to help, for ourselves and our patients, rebuild senses of control and empowerment. How many people have been to the DPH, Trauma-Informed Systems training? So a couple. I would highly, highly recommend going to this training. I really appreciate that they've adopted these trauma-informed principles, and I keep them in my mind while I'm practicing and wish we kind of had these posted up around the campus to remind us of how we can practice in the most healing way. They define a trauma-informed system as one like SAMHSA that would be healing for all of us who are living and working in the environment, so not just for our patients. And I'd like to call your attention to cultural humility. I would highly encourage you to watch the Vivian Chavez video about cultural humility. It's a really useful lens to think about trauma-informed care because it discusses lifelong learning about ourselves and our own points of power and privilege or lack thereof, and how that affects the power and privilege dynamics that happen in relationships and how to mitigate those power imbalances. So I think it's a really useful lens. But again, focusing on all these as we care for patients, I think would markedly ground our care in a really positive way. So this is, as I've said before, sort of the Sesame Street portion of my talk. So letter C, not sure, I need a linguist. I haven't had a discussion with a linguist yet to figure out what it is about the letter C. But there's something about the letter C and trauma-informed care. You could think of other C's besides the ones I've picked, like compassion or connection. But these are the 4 I picked. And full disclosure, based on my read of sort of the biological literature as well as the clinical literature and my 20 years of experience talking to people about trauma and adversity in their lives, I made this up, and it hasn't been tested yet. So this is a paradigm that I think is really useful, and I've run it by trauma experts, and they feel like it does well reflect what we understand and know about trauma and resilience. So let's start with a case. Ms. Jones is a 44-year-old woman. She comes to her first primary care visit, and she's complaining of pain and insomnia. She has diabetes and asthma. Both are very poorly controlled. So she goes to the emergency department frequently, where she complains of pain, shortness of breath. She's been found to smell strongly of alcohol when she's been in the emergency department. And she is already very upset with me because I am late for her appointment. And I am often late for appointments. I run quite a bit behind in my clinic, and that is already, I need to recognize that that is not a trauma-informed practice, right? If someone was repeatedly betrayed as a child and what they were promised was actually broken every time they were promised something, and they were actually treated poorly by someone who is supposed to care for them, I know before I step in the room, she has multiple uncontrolled illnesses, she has chronic pain, and I am late, and that is not a trauma-informed practice. It still doesn't mean that I am going to figure out how to be on time, because I haven't yet. But it means that before I walk in that door, I am actually going to calm myself. I am going to feel as rooted and grounded as possible. For me, trees work as an image, whatever works for you to help you slow down your breath, lower your voice, sit down really calmly, focus really powerfully on the person and not the computer. Whatever helps you do that, I know that I need to do that as I'm entering each room. So I'm modeling calmness for the patient, and I'm also know that human beings co-regulate emotion subtly without any verbal communication. We co-regulate, and so I'm using my body and my breath to create a sense of calmness in the exam room. I'm also staying calm because rather than sort of being overwhelmed by the fact that Ms. Jones has all these uncontrolled, very serious illnesses, I'm actually assuming that trauma and adversity in childhood could be the root of a lot of these problems. I'm expecting that change is going to be actually quite slow, and that my goal is to really model a healthy and reliable and dependable relationship. So again, I under-promise and over-deliver. I try to be very, very careful about not promising things that I will not follow through on. I prioritize sort of safety and dependability, and I'm focusing as much as possible on resiliency and also on cultural humility and power dynamics. You know, what does it mean for me to walk into the room with a person of color as a white person, and how is that affecting what gets said or what remains unsaid in the visit until I demonstrate that I understand the health effects of racism, right? So it's practicing in this way that I've described. So what is happening under the surface? Miss Jones' father was incarcerated for domestic violence when she was 10. Her uncle moved in ostensibly to help out, but instead sexually abused her for 3 years. She began drinking at age 10. She did very poorly in school, and her mother actually felt like she was so out of control that she couldn't handle taking care of her, so put her in a group home at age 13. And she really remembers her favorite aunt as the main sort of stable person who really she felt loved her very much as a child. So the next C, contain, I'm going to talk about, is that I want to make perfectly clear that we do not need to know the details and all the specifics of a childhood trauma history in order to deliver very wonderful strength-based trauma-informed care to our patients, and that you really need to pay attention to what is the context of your visit and not try and elicit details when you're in, for example, a 15-minute primary care visit, because your goal is that the patient would walk out of the visit feeling, rather than feeling super triggered by the encounter and destabilized by the encounter, the patient would feel like the encounter was a healing and more stabilizing encounter. So again, gauging and knowing that the elicitation of a detailed childhood trauma history can be incredibly triggering for people, and that that's not our goal. We're actually trying to contain the history. So you can provide a lot of education without asking people for disclosure. And again, just paying attention to what is the context and what is the time for the visit. I'm going to make a distinction between eliciting a childhood trauma history and talking about adulthood intimate partner violence, because I think actually it's been well studied and well proven that you can talk to your adult patients about adulthood intimate partner violence without destabilizing or causing harm in the visit. This has been really well studied, and there are multiple studies. It's safe, effective for as long as we have the ACA. It's actually required that we do education, screening, brief counseling, and referral. And there are multiple sort of simple tools. We feel like there are sort of problems with a lot of them, so we've devised our own questions that we've been using for over 20 years. So has your partner or anyone else hurt you, hit you, or threatened you? Has your partner or anyone else forced you to have sex or do something sexual you didn't want to do, or forced you to try and get pregnant, or interfered with your birth control? Because this is a shockingly common problem, reproductive coercion. We can see that also being played out on the national level, but people are constantly trying to control the reproductive life of their partner. That is something that we can do something about, because you can offer non-disclosure based hidden birth control methods like a depot shot or an IUD with a string cut short, and doing that, just simply offering those methods and saying, you know, we know that people can mess with your birth control or interfere with it, and so we have hidden methods of birth control. That was actually found in a Planned Parenthood study to reduce reproductive coercion by 71%. Didn't require disclosure, just offering that we know this kind of thing happens and we can give you a hidden method of birth control. So if you are talking to people about early childhood traumas, or you're trying to figure out how to address this, first of all, knowing that an early onset of substance use or mental health problem is actually almost pathognomonic for childhood trauma, right? So I know if Miss Jones started drinking when she was 10, something really difficult happened in her childhood. And you'd be surprised at the number of our patients, if we ask them, how old were you when you first remember being depressed? And a lot of my patients cannot remember ever not being depressed. So again, that tells me I don't even have to ask detailed questions to know that person had a really difficult childhood. So I do, after I get to know my patients, talk to them about childhood issues, and when I do that, I try and explain why I'm doing it, that how we were treated as children can actually affect our health later in life. So I want to ask you about these things. I ask people who they grew up with. A lot of times people don't understand what I mean when I say, how did those people treat you? So I'll say something like, you know, some family members and friends really cheer you on and support you and always build you up and make you feel stronger and better. Some actually criticize you, put you down, hit you, hurt you, or abuse you in some way. I actually try and avoid that word, abuse. How did your family or your caregivers treat you? So I will, after I've established a trusting and sort of safe, stable relationship, sometimes discuss these issues with patients. So for example, if Miss Jones tells me on the very first visit that she was drinking when she was 10, I will try and do a sort of containing script that, in my experience, when a patient tells me she began drinking at age 10, it is because difficult things were happening during childhood, and we're just meeting each other for the first time today, so we don't need to go into those details, but I just want you to know that if you ever want to discuss this in the future with me or a therapist who specializes in trauma or difficult experiences in childhood, I'm happy to refer you. So I make it clear that I understand something difficult might have happened. So sometimes if I use a sort of containing script in that way, people will just acknowledge that, yes, that happened. I had a woman who acknowledged that she was sexually abused as a child by her uncle, and that she had been in therapy, and it was not really affecting her too much anymore, although she felt like it was actually affecting her work, because she worked with young children and she felt overprotective of the young children. So when people tell me without obvious distress a trauma story, then I acknowledge, you know, thank you so much for sharing this information with me. If you don't know what to say, saying that you're really sorry that that happened to someone is, I have found, pretty uniformly accepted and appreciated by patients. So then trying to figure out, how do you feel this experience has affected you? Because there's any number of ways in which this may have affected the person's life. If instead a patient becomes upset or tearful or distressed, again, my goal is to help this person feel put together when they leave the visit. So I will tell people, you know, that gradually over time we can talk about this, but it's really important that this be a healing place for you, that you can come back to and feel like you want to come back. So I do practice deep breathing with my patients, or I've been amazed lately talking to our patients about prayer. A lot of our patients who don't go to any religious services or consider themselves religious actually pray. So I'll ask people, you know, is there something that helps them feel calmer that we can do for a moment together? So care, the third C, this really refers to developing a very deep compassion for ourselves and others, to understand that it is our experiences and our relationships that have built our behaviors and have resulted in these outcomes. So it helps destigmatize, I think trauma-informed care helps destigmatize adverse coping behaviors, because we think, instead of thinking, you know, kind of what's wrong with you and labeling people with a diagnosis, we think, what happened that resulted in these problems? And I will say that people have incredibly complex feelings towards people who have hurt them. And so I am really careful to always acknowledge people's conflicting feelings. They may feel love and hate at the same time. They may feel anger and forgiveness at the same time. So I'm really careful to acknowledge feelings and just explore what feels the most healing and the most helpful for the patient. So I will surprise people by telling them, no wonder you started drinking when you were 10. You know, you needed to find a way to cope with a really impossible situation. And I will say that even just saying something like that is so healing for our patients, right? Because these are such stigmatizing topics. And so even knowing that you think it makes perfect sense that this could have happened, and that it was a coping strategy that did help in probably multiple ways, that can be a really healing experience for a patient to hear that you understood that they were trying to cope with the situation. Again, if you don't know what to say, saying you're really sorry that that happened is very well accepted. And then the final and the most important C, cope. The more I get into trauma-informed care, the more I realize that I should be really thinking of it as resiliency-based care, because you are trying to figure out what are all the skills, the behaviors, and the interventions that help that person build up a more healthy sense of social connectedness in life and really help them recognize how they have survived and what they are doing to survive the difficult experiences that they've been through. So I tell people I'm really glad that you came in today and that you had the strength to do that. I'm reminding people of positive things in their lives that give them the feeling that they have, rather than like guilt and shame, a deeper sense of self-worth. So I'm reminding Ms. Jones about her aunt and maybe asking her to tell me more about her aunt and her relationship with her aunt, so that I understand and can access a part of her that feels like she is worthy of love. So where you're really using these skills and behaviors to build upon hope for the patient. The fastest way to figure out what works for patients is to simply ask them, when you are stressed out, how do you cope? And you will get such a wide variety of answers. Someone I have in my clinic who has complex PTSD and constantly comes in saying that she is feeling suicidal. When I asked her this question, she whipped out her phone and said, I listen to this ocean app that has the sound of the ocean, and it makes me feel so much more calm. And I could have gone through like a whole lot of doctor talking ideas and never gotten to the ocean app on the phone. So I find that it's much more efficient to basically ask the patient what they do to cope. And then it may be that they tell you very honestly that, they use cocaine or they use alcohol or they do something that is ultimately like harmful in many ways to their health, but that is their coping technique. And then I go straight for, well, wow, like how does that help you? How does that make you feel better? Like let's really explore very deeply, like what are the things that are drawing you towards using this substance to feel better, and how does that work? Because ultimately, if we're going to figure out how something else works, I need to understand what are all the ways in which that coping technique is working for this patient. Dean Schillinger made this mnemonic for me and for him as we talk about this topic together now. And so, again, I'm trying to figure out what are all of the ways that patients can feel some sense of empowerment, some sense of control, some sense of self-efficacy. And I'm exploring those. And the more I've come to do this, the more I've realized that these are my tools, right? Like these, helping the patient really deeply explore what things work for them to feel more healthy and whole and strong. Those things are the tools that we have to help them build back up from the stress and the experience of trauma. So I'm spending a lot more time in my primary care visits now discussing what is working for patients. You can, of course, also refer to trauma-specific therapy, and I will just say that the things that trauma-specific therapies, of which there are many, have in common is that they try to address the emotional regulation skills that people may be having difficulty with. They try to address the relationship problems that people may be having and enhance relationship skills. And then ultimately, if people are stabilized enough to do some deep exploration of the trauma that they experience, which may or may not happen, people may not be stabilized enough to do that, but if they are, a reworking and a reprocessing and a reframing of the trauma narrative is a key element of most trauma-specific therapies. Of course, we know that we have to address all these other social determinants of health that are causing trauma in the patient's life as well. Again, just kind of take a deep breath. That's a lot. And take care of yourselves, which is absolutely important when providing trauma-informed care. I'll stop there and take questions. Questions or ideas? I'm learning every day about this. Yes. Edgar.
When I saw a presentation on the use of virtual reality, virtual reality to treat people in the military who are suffering from severe PTSD, and it takes them back,
right,
in a virtual reality kind of way to some of these experiences that they had. And I'm just wondering, has that been extended to the patient population you're talking about?
Well, I don't know that virtual reality specifically has. Certainly, our visual systems are really, really powerful, and visually graphic details and smells. Like, there are certain sensory experiences that really are very sticky for our brains in terms of traumatic experiences. So I can see how, visually re-experiencing something could be really powerful. Most of the trauma therapies that I'm aware of for safety net populations are either a reprocessing through therapy. There's also EMDR, which is eye movement desensitization. So while someone relives trauma details, they actually do rapid eye movements from left to right to try and reintegrate different pathways in the brain. So there's a lot of different therapies that are being experimented with, but I'm not aware of us yet using visual reprocessing or virtual reality. People just need to be very stabilized, you know what I mean, before and it needs to be done by a very experienced therapist who understands how to keep someone stabilized while they bring up their trauma history. Other questions? Bobby, hon.
In pain clinic, we see a number of people whose pain doesn't fit any particular pattern, and it's only when we say to them, were you safe as a child, that we learn about a lot of this stuff. And it's only when that is addressed in a more formal way does the pain ever get any better.
Right. So I think this is a really underexplored area, the connection between pain and trauma. And what we are starting to learn is that people's pain thresholds are much lower with having experienced traumatic stress as a child, and as well, our brain is remodeled in sort of how we experience pain. So we end up sometimes trying to treat emotional pain and psychological pain with physical techniques that are not addressing the underlying problems. Lisa.
Yeah, so this is great, and you addressed this a little bit, but with respect to resources. So a lot of behavioral health is embedded in primary care.
Right.
And as specialists, we sometimes unearth this, but then we struggle to figure out how to get our patients the kinds of services that they clearly need.
Right. I mean, I think first of all, I wouldn't underestimate us focusing on on coping techniques and talking a lot more about what has helped the patient survive and really supporting those practices. I do think behavioral health, we're working with behavioral health on a grant on adulthood interpersonal violence and doing a lot more training about trauma-specific therapies with our behavioral health teams. So I think that they already have, some ability to do some really positive work with our patients around the topic of trauma. Trauma Recovery Center, we're hoping we can sort of enhance referrals for, not quite as recent a trauma, but the resources aren't there yet for that. I will say that when I refer people to Access or mental health services in the city, I do actually ask whether there are therapists that specialize in working with patients with a high burden of trauma, so that I at least have some idea that the patient is getting an experienced provider. But I do think that our behavioral health clinicians are really, this was the top-rated topic that they were interested in working on, is trauma. So I think that it's they're really interested in working on this. Yes?
The exact question is like the subspecialty of trauma-based care. What do you do with people who are like engaging with therapists and then you find out that there's more stuff that they haven't told their therapist?
Uh-huh.
They're like, well, we're already working on this issue. I don't want to work on this yet. Like,
Right.
There's everything not comfortable with trauma.
Right. I mean, I think that, first of all, that's kind of to be expected, that people, again, I said, when I'm sitting, I sat with a colleague who's a black woman physician who told me what her patients come in and say. Her black male patients walk into the visit and say to her right when they get there how traumatized they were just to be on the street getting to the appointment, and how stressful that was and how frightened they felt. That's not something like my black male patients say to me until they get to know me, like many visits later. So I think it's to be completely expected that people would tell different aspects of their trauma to different people based on power and privilege differences, based on how comfortable they feel with that person. And I just support people with, does it feel like the therapy is working for you if you're not talking about that? Or do you actually feel like, this is something you want to talk about? And you don't feel safe talking about with this person. So that would be a different story for me. And if the person felt like they wanted to talk about it and they didn't feel safe talking about it, I would help them understand that it's not rupturing of a relationship to switch therapists, but instead is moving towards a really healthy healing relationship to switch therapists.
How do you deal with like the language barriers? So if you have somebody who speaks another language and making sure that you're communicating in a culturally sensitive way and vice versa, that you're understanding what's coming through the translator.
I find this a really, really challenging topic because what I've noticed in working with interpreters, especially when it's a phone interpretation, is that it's incredibly stressful, I think, for the phone interpreter to be hearing trauma histories while being sort of disembodied from like the physical and emotional relationship in the room. I think that's like a really triggering experience for the interpreter, and I think that you can't know whether the interpreter is feeling safe or comfortable translating like what you're saying. So I will actually tell the interpreter ahead of time what I'm going to be discussing first. I'm going to ask this patient a very direct question about whether their partner has been hurting them, and I'd like you to translate it the way that I'm asking it. But I'll give them a little heads up and a little warning. I think that if you're discussing trauma history, it would be immensely more helpful to have an in-person interpreter than a phone interpreter. And again, I think sort of doing a little pre and post debrief with the interpreter would be really helpful, because I think it's very stressful. And I think asking the interpreter what did they feel like something that you're asking them to say is not culturally appropriate in some way, and do they have a way that they would prefer to word it? But I asked them to explain that to me, because a lot of people, every training I did at every health center for 20 years, I would go everywhere and everyone would say, in my culture, that's taboo, we can't discuss that. And every single culture felt like certain topics were about violence and trauma were taboo, yet my patients were discussing these topics with me, right? So I think asking for feedback, but then not feeling like you can't ask about these topics because they're important. I'll stay up here if people have more questions. I can only stay for about 5 more minutes. Yeah. Okay. Thank you.
Thank you. Perfect. So
okay.
If you
Sorry,
get more
I was breaking early.
If you get more
Okay.
questions, you can. Yeah.
Here, I can grab your microphone. One second. Maybe, since you don't want to go up my
We can go
shirt.
earlier too.
Yeah.
Just a one.
Thank you. Thank you. Thank you.
Okay.
Oh, here's your output. Right here.
Oh, nice.
So could you, what I'm going to do is if you could just turn on the system.
Sure.
I'm going to ask, I don't need to keep you here, but I'm going to ask one of them to talk into the microphone once I have my thing set up over here.
Sounds good. And we have the lecture mic right here picking up.
And if people bring their if she brings a thumb drive, is they able to bring it up on here?
Yeah, there's a couple of USB ports right here. We can drop them on. That's how we did this presentation today. We've got a couple PowerPoints left over from other days as well. Yeah.
And then we
works fine.
just, how then do we, how do we open them up?
Double click. It's a PowerPoint presentation. We have the PowerPoint loaded on here.
Right,
That's
but if I were to
the
put
full
in a
screen.
USB port,
Oh,
how would I find it?
well, it'll pop up immediately asking what do you want to do with the
Oh,
drive.
that's right,
Open
and
the
then it'll say
drive.
open file, okay.
Yeah, and if you didn't see that, you can always open up this computer, and you'll see